Good morning, everybody. This is Dr. Ahmed Amin Nasser, and today I'll be talking to you about perioperative challenges regarding implantable cardiac electronic organizers, iCEOs, and new updates. All hearts are born equal, regular, and strong, but then some hearts become fatally slow or fast or even failing. Bradycardia disorders like sick sinus syndrome or complete heart block, atrial fibrillation with block would require a pacemaker. Ischemic malignant ventricular tachycardia or ventricular fibrillation necessitate overdrive pacing and defibrillation. Congestive heart failure and cardiomyopathic conduction delay with biventricular dysynchrony would call for biventricular resynchronization pacing. Both the heart and its implanted cardiac electronic organizer enter in an inseparable bonding, best described as arranged Catholic marriage by cardiologist and device programmer, where unambiguously there is no return, all in oneness till the end. CEO senses and organizes the heart. Arrival of any seductive competitor would only cause confusion of this inextricable bonding. An issue of low fidelity, noise, clouding pacemaker action would demand a vigilant presence of a pacemaker to prevent wrecking the whole machinery. iCEOs, also known as Implantable Cardiac Electronic Devices, iCEDs, are just mini computer and a battery in a can, implanted under the skin with leads connected to heart chambers. Right atrial lead to right atrium, right ventricular lead passing through tricuspid valve to right ventricle, and left ventricular lead passing through the coronary sinus into a posterior coronary vein pacing the left ventricular free wall. Chest X-ray is a very important tool to find about pacemaker story. It tells its presence, circuit integrity, number of leads, anti-bradycardia or anti-tachycardia function. This particular chest X-ray shows a can, atrium lead, right ventricular lead, so it is atrioventricular implantable pacemaker, AVIPM. Here, another X-ray showing implantable cardioverter defibrillator. Besides the battery, there is a capacitor. And there is also, the slide also shows a piece of ECG with kind of anti-tachycardia pacing, which is a programmed burst of overdrive pacing at shorter RR interval, terminating the ventricular tachycardia. Defibrillator delivers 30 to 45 joules from an added capacitor. In the case of ventricular fibrillation, or if anti-tachycardia pacing fails, shock passes between the defibrillator two coils. Shock delivery is painful to the patient and utilizes more battery life, more than anti-tachycardia pacing. In anticipation of post-shock bradyarrhythmia, there is underlying pacemaker ready to take over in such case. This is a chest X-ray showing biventricular leads where biventricular pacing guarantees synchronous depolarization and contraction of both ventricles. This cardiac resynchronization therapy, CRTP, has been associated with improved ventricular remodeling, symptom improvement, and hence decreased hospital stay. Here, CRT defibrillator is added to the CRT pacing in cases of malignant ventricular tachycardia or ventricular fibrillation with congestive heart failure. ECG is another important tool for showing IPM characteristics. Midnight emergency cases lucky when you find ECG besides the chest X-ray. Spiky ECG. Spikes timing to QRS complex. And look for the complex, whether it is narrow or wide complex. Pacing shows the spike, the pacing spike, followed by wide QRS. If there is no pacing, then there will be no spike and the QRS more likely to be a narrow one. Asynchronous pacing at regular interval in total disregard to myocardium, resting, depolarizing, or repolarization phase. The spike might come through the beat, creating problems if the heart is paced near the end of T repolarization wave, R on T, that could bully the heart into ventricular fibrillation. Extent of this pacemaker R on T threat was not well studied, but motivated creation of sensible pacemakers. Synchronous pacing. On reaching maturity, pacemakers got the feel of the heart before deciding to pace or not to pace. So looking at the ECG with pacemaker, you look for the spike versus QRS complex, slim or narrow or wide. Here, you notice at the first beat, the pacemaker sensed both the atrium and ventricle, yielded the right of way, so no pacing at all. There is only spontaneous P and QRS. But the second wave, only the atrium is sensed, but the ventricle was not sensed at all. So after certain delay, the ventricle was paced. So that's what you call triggering. After a delay of atrium, normal spontaneous contraction and impulse, there is pacing of the ventricle. Now the third beat, you would find that both atrium and ventricle were not sensed at all. So the pacemaker went on and paced both of them. So AP and VP. The fourth beat, you would find that the atrium was paced, however the ventricle was sensed. So the pacemaker was inhibited, yielding the right of way to the ventricle. This is the ECG pattern in cardiac resynchronization therapy. It could be guessed. It's a kind of combined left bundle branch block and right bundle branch block. So it is big R and big S in V1. This is the weirdest classification ever, giving 5 letters to differentiate types of IPMs. Historically, all started with pacing, but strange enough, after successfully adding sensory function that determines the response, both never made its way to first and second letter. Besides, none at the first letter makes no sense, the whole classification collapses. Also, triggered only pacemaker is physiologically impossible. On the other side, rate modulating has accelerometer sensing exercises and changes pacing rate accordingly. In theater, it is idle anyway. Biatrial pacing may prove futuristic. Now, DOO, when the pacemaker moves backwards to asynchronous pacing mode of the 60s, which is unliked by cardiologists because of R&T threat, and also unliked by trade unionists because DOO means driver only operator, which could be taken as pacing only operator. Here is a simpler approach or functional approach to understanding of implanted cardiac electronic organizers. It has nothing to do with any exam, but rather improved understanding. When you start with the primary step, our primary function, which is sensing. So far, you can sense the atrium, or the ventricle, or both atrioventricular, or atriobiventricular, or AVV, or no sensing at all. That is followed by planning a response after sensing. Either inhibited, or inhibited and triggered, both together, rate modulating, or none means nothing at all because there is no response and it is going to be asynchronous mode. Finally, the function or the action of the pacemakers, either antibradycardia pacing, atrial, ventricular, or atrioventricular, IPM, implantable pacemaker, resynchronization pacing, CRTP, cardiac resynchronization therapy pacing, or anti-tachycardia pacing as well as defibrillator, AVICD, and finally combined CRT-PD pacing and defibrillator. At last, the off mode, which could be a programmer task or done by bedside. This classification is intuitive, helps understanding function of iCEOs. Asynchronous IPM did not live long enough, as R&T was intimidating. Sensory function and inhibited triggered IPM response were added as a master program, while asynchronous pacing became a slave backup program. ICD, or Implantable Cardiac Defibrillator master program, joined the pack, and ITIPM became its slave program. Inhibited triggered IPM became its slave program. That would work in case of sudden bradycardia. So there is always a working master program, and in case it stopped or failed, next in command slave program is activated. Shutting down cancels out any master program, leaving behind the backup slave one. As IPM is shut down, ITIPM is shut down, you would find asynchronous IPM. And because of the possibility of R&T and ventricular fibrillation while you are shutting down ITIPM, you should have the defibrillation pads ready to be working in such case. ICD shutting off will leave behind ITIPM. However, precautionary defibrillation pads are not needed here, as ICD shutting down could be immediately reversed by taking the magnet away. So the ICD could come back functioning as defibrillator or anti-tachycardia pacemaker. Now, in case of computer malfunction, first step is usually shutting down and then restarting. Same applies for pacemaker's malfunction. This ECG shows pacemaker-induced reentrant tachycardia, pacemaker antegrade limb, and atrioventricular node as its retrograde limb. Now you shut down this pacemaker into asynchronous mode, then restart it again back to normal IT-IPM, but you got rid of the pacemaker-induced tachycardia. On the other side, in cases of patients with sudden appearance of atrial flutter, the ICD may sense the high ventricular rate as ventricular tachycardia, then it overdrives the ventricle. But when this fails, it will shock the heart, which is very painful to patient and could be more frequent. Immediately you shut down the ICD, leaving the IT-IPM behind as the new master program. Reprogram triggering ICD could follow to a higher ventricular rate in order to get away from this effect. Of course, beta blocker will be prescribed. And if it doesn't work, you can take this ICD away. Shutting down could be done through reprogramming by computer, but in emergency situation, it could be activated by bedside, applying a magnet. Now, have you ever wondered how the screen of your laptop or your old flip phone go dormant once you close the device? The secret is reed switch, which is a ferromagnetic switch consisting of 2 reeds and 2 contact plates. If a magnet is applied to its periphery, contact blades become far apart, breaking the circuit as shown with the horseshoe magnet. Point of care shutdown is placing a magnet that will close the master program and unleash the backup mode. This is called the magnet off mode. To magnet or not to magnet? The everlasting question whenever iCEO makes its debut to operating room. Magnets come in 40 shades of colors and shape. When the magnet is correctly placed over the device, beeping tones appear 1 second later and for 1 long minute. When was it you last used such magnet? One might wonder when magnets find its way to the Advanced Cardiac Life Support course in order to familiarize people with that. In noisy operating room, we magnet to increase fidelity of iCEO and stop responding to any seductive noise. Smart magnet with a light indicator to guarantee appropriate placement. Anyone can magnet. Why can't we? Even Apple could play magnet. iPhone 12 magnet applied to the can could work and suspend any master program and reveal the slave backup mode. Noise in theater may change device behavior, resulting in damage or failure. So perfectionists would refer them postoperatively to cardiology. However, modern devices are resilient and more resistant to noise-induced behavior changes. We live in a sea of electromagnetic waves, radio waves, microwaves, visible light, ultraviolet waves, as well as ionizing radiations. Some will interfere with these devices, and some will not. All depend on wave frequency tracking pacemakers. Higher frequency waves, ionizing radiation, and ultraviolet light are unlikely to cause interference, though might cause direct damage. In operating room iatrogenic electrosurgery diathermy use radio frequency of 0.5 to 1 MHz, which are very notorious of reaching out seductively to pacemakers. Diathermy electrosurgical unit. Radio frequency inducing tissue ions alternate vibrations that result in maximum heat, which affect cutting and coagulation, hence bloodless surgery. Monopolar diathermy current passes through the body from point of contact and maximum heat until it reaches a diathermy pad, long, wide pathway, decreasing the effect of heating on one side, but on the other side increasing the likelihood of interfering with pacemaker, especially if surgery is less than 15 cm from the can, so it is too noisy. On the other side, bipolar diathermy current passes through the teeny-weeny tines directly through the tissues, minimizing the likelihood of interfering with iCEO. So it is minimalistic noise-wise. It is used if surgery is less than 15 cm from the can, provided no direct hit nor fulguration is attempted, where electromagnetic waves could drag pacemaker through the air. In everyday life, patients with pacemaker will construct a balance between their heart, their electronic device, and any noise or noisy electromagnetic interference. In theater, this balance should be at its maximum because of added surgical stress and identified iatrogenic noise. Anesthetist is guaranteeing this balance. A multidisciplinary approach and summoning of all possible helps, patient history, cardiology input, mainly pacemaker dependency, programmer input, battery check, 1 year for IT-IPM, but 6 months for ICD as shocks exhaust the battery faster. Surgeon, electrosurgery diathermy. Beware that midnight emergency cases, only surgery anesthetist bilateral approach is the choice available. The issue of pacemaker dependency is a tricky and complex one. Even no agreed upon definition. Thank God it is rare. We guess it is too much to be included in any protocol, while scarcely recognized in patients' clinical follow-up. Anesthetist work preoperatively should focus on ECG and chest X-ray, as well as diathermy noise, sight and form, radio frequency, microwave, laser or otherwise, and also magnet whereabouts. Get history, but don't sweat over dependency unless unambiguously stated by cardiologist. Identification cards never found. Other things as appropriate. Don't forget, it's always noise versus magnet. This algorithm, which was released in 2016 by the British Journal of Anesthesia, seems to me very stiff and a stark reminder of my initial continuous failure with London Underground. A simpler, intuitive, easier algorithm could be suggested as: in cases of patients with implantable cardiac defibrillator (ICD), if surgery is below umbilicus, use monopolar diathermy. Above umbilicus, use bipolar. If surgery within 15 centimeter area, any electromagnetic interference may release shocks. So go ahead and magnet paralyze the shock and defibrillator. If ventricular tachycardia or ventricular fibrillation happen, take the magnet away and leave it for the ICD to tackle the issue. Then bring it back. Now, if patient with implantable pacemaker IPM, if surgery was below umbilicus, use monopolar. If it's above umbilicus, bipolar. Surgery less than 15 centimeter away, reprogram, or just use a magnet to get asynchronous IPM with precautionary defibrillation pads in place, just in case. In theater with a magnet ready and vigilantly observing your patient. The question is when and how to magnet. Hopefully now you have rehearsed that before attempting it. Any bradycardia, any tachycardia outside the allowed paced heart rate or any frequent shocks, use the magnet off mode. Post-operatively, routinely, it's always said, continue observation for any intruding seductive noise. But then the question would arise, what sort of noise we are expecting post-operatively? I don't know, but if I were you, I would just refer these cases to cardiology to guarantee iCEOs' future welfare if things went wrong during surgery. Now, this happy man has got a pacemaker. Is he allowed to be watching Aurora, the goddess of the dawn, at the northern pole where solar winds are trapped in Earth's magnetosphere? In order to make himself happy with these spectacular light colors? He fell and broke his shoulder. Now, how would you conduct anesthetics? Could we use his iPhone to check for electromagnetic interference out there or even in theater? They claim that ElectroSmart app is made for such purpose. Or could we all routinely use iPhone to familiarize ourselves with such sea of electromagnetic waves we are submerging our patients into, whether they have got pacemaker or not? Or better still, theaters could be supplied with electromagnetic field meter to practically clarify effects of any electromagnetic interference, be it radio interference, unipolar, bipolar, or microwaves. And also to define the iCEO danger zone, the 6 inches, 15 centimeter area, or what we love to call pacemaker Hertzian comfort zone, where any electromagnetic interference is not welcomed. Finally, thank you for such wonderful time spent while working as a locum consultant at Royal Glamorgan, ITU, and theaters. I loved it. You have received me very well during these hard days following my illness with COVID-19. You have given me vaccine without hesitation. As my last case was midnight emergency laparotomy for a patient with a pacemaker. This review lecture was made as a token of gratitude to my anesthetic, surgical, and ITU team. Thanks million times.